Welcome everybody. This video is all about Impetigo. And flashing up on the screen now is a general overview of what we will be discussing. I've never really used PowerPoints before, so apologies for the slides. I will try and think of a better way for next time. Any suggestions welcome. Impetigo is a highly contagious bacterial skin infection. It's the most commonly seen skin infection in young children in the UK, but it can affect all ages. There are two main types of impetigo. Non-bullous is the most common type, and that presents as small pustules with or without surrounding erythema, which is redness. The lesions are not usually too widespread, and patients are usually systemically quite well. The bullous type is less common, and bullae just means a fluid-filled blister greater than 1 centimetre, and that can occur anywhere on the body. The non-bullous type is usually caused by the streptococcus or staphylococcus, which are both gram-positive bacteria. The bullous type is due to Staphylococcus aureus, which produces exfoliative toxins A and B. They cause a dissociation of epidermal cells, which causes the blister formation. So, impetigo most commonly occurs in children and infants. Can also be due to poor hygiene and exposure to contaminated surfaces. Crowded conditions, such as schools and nurseries and care homes, can increase the risk also. The skin barrier, if intact, usually keeps these pathogens at bay, but cut or damaged skin can increase the risk. And certain medical conditions, such as diabetes and immunosuppression, can also contribute. Some people are natural carriers of S. aureus, and this can be confirmed by a nasal swab. Also, high humidity environments and hotter months can also increase the risk. And then we also have insect bites, trauma, and eczema, which fall under some of the other categories. So, some of the symptoms are non-bullous then. We have honey-coloured crusting of the skin, which actually spreads quite rapidly and can be very itchy. Will usually start as 1 or 2 red spots, then quickly up. It is usually seen around the mouth and can often start from the cracks in the corners of the mouth. Red marks can be left, but usually heal after about 2 or 3 weeks. So in bullous impetigo, the lesions or bullae are bigger and can appear anywhere. They will still burst to form a honey crust that may be more painful with surrounding skin still itchy. As mentioned earlier, the patient is more likely to be unwell with systemic involvement, such as fever, diarrhea, or weakness. So on to diagnosis then. Investigations are easily needed. Clinical features are usually enough. They're quite apparent. A way to look at contacts of the patient that may have a similar rash. Past medical history can be useful, such as eczema and immunosuppression. And you can ask the patient if there's been any previous trauma to the skin. In persistent cases, swabs of the infected area can be sent for culture and sensitivity, or a swab of the nasal passage. The possibility of MRSA must also be considered. So, when assessing a patient, we also need to consider what else it could be. It could be the bacterial skin infection, fungal skin infection, a parasite such as scabies, or could it be a viral condition like shingles? They can present very similarly. It could be a more infective cause, such as dermatitis or an insect bite, or even a drug reaction or a burn, a scald, especially if the skin is red without crusting, as in the early stages of impetigo. So taking a patient history is very important. Don't just assume. Because impetigo is a bacterial skin infection, some complications may develop, especially if the patient is of poor health. These may include cellulitis, which is an infection of the deeper layers of the skin, sepsis, which is a life-threatening reaction to an infection, or permanent scarring, usually due to the skin being unable to heal with persistent scratching, or scarlet fever. This may develop from any streptococcal skin infection. On to treatment now. Non-bullous impetigo is not usually serious and often improves within a week with treatment or a few weeks with self-care measures. So first of all, it's best to try and remove the crusts by soaking in warm water or saline. This alone can take time to resolve the problem in a few weeks. But if cream has been prescribed, it will help it work better and also prevent the dreaded picking by the children. Pharmacological treatment in the UK is as follows. First line is hydrogen peroxide 1% cream, applied 2 to 3 times a day for 5 days. If that's unsuitable, the next step will be to prescribe fusidic acid cream, 2%, 3 times a day for 5 days. Fusidic acid cream is a prescription-only medicine in the UK, but it's now available from the pharmacist under a patient group direction. Now, it's worth mentioning that these creams are suitable for lesions that aren't widespread. If they are, then oral antibiotics will be preferred, as for the bullous type. This would be flucloxacillin 500 milligrams 4 times a day for 5 days in an adult. Dosages for children will be dependent on age group. If allergic to penicillins, we could offer clarithromycin 250 milligrams twice a day for 5 days, or 500 milligrams twice a day if severe. Okay, this is just some extra information on the different treatments available. Hydrogen peroxide is an antiseptic and it's applied in a thin layer. Please warn the parent or the patient that they may experience a burning sensation on application. This may be a compliance issue in young children, so have that conversation with the parents and use a shared decision-making approach. The cream is not to be used at the same time as topical iodine or permanganates, which are often used for fungal infections, but systemic absorption is unlikely. And for those of you that are interested, the cream actually kills pathogens through oxidation burst and local oxygen production. I actually didn't know that, so even I learnt something new during this one. Fusidic acid now. Fusidic acid is a narrow-spectrum antibiotic used to treat staphylococcal infections. You need to avoid contact with the eyes and do not use for longer than 10 days to avoid resistance. Some side effects, possibly sunscreen reactions, but that's uncommon. These are quite well-tolerated creams. Flucloxacillin now. Fluclox is a penicillin, and these are bactericidal. They act by interfering with bacterial cell wall synthesis. They diffuse well into body tissues and fluids, are ideal for skin infections. I could just see these arrows bouncing up and down and I don't know how to stop them. I'm so sorry, everyone. Some safety information associated with Fluclox is cholestatic jaundice and hepatitis. This may occur very rarely, up to 2 months after treatment. Some risk factors for this are treatment for longer than 2 weeks and increase in age, so care is needed in patients with hepatic dysfunction and impairment. Also, it's important to check if the patient is allergic or had any previous reactions outside of the normal side effects profile. Remember, if they have had a bad experience with side effects previously, even if it's not a true allergy, compliance may be a problem. We also need to check for any drug interactions. It could be a problem, such as warfarin and methotrexate. Most common side effects of penicillins are diarrhea, nausea and vomiting, skin reactions, and hypersensitivity. We can give some advice to patients then before they leave your consultation. Due to the infective nature of the disease, it's important to keep the skin clean and don't share towels, etc. It's also a good idea to wash clothes and towels on a hot wash to prevent spreading. People that work in the feed industry in the UK are required by law to tell their employers if they have Impetigo, though. And as for work and school, it's generally okay to go back 48 hours after commencing antibiotics, but it's best to stay off until then or until lesions are crusted over and completely healed. Okay, safety letting and follow-up. Please do not let the patient leave without giving safety netting advice and advice on how to use the treatment properly. This is especially true over the weekend. In the UK, primary care is especially limited, so make sure they know who to contact if symptoms get worse, or if through the week they could always come back to see yourself. Also, to get reasonable expectations on treatments and when they are likely to see improvements, or they will just come back the next day saying it hasn't worked. Also, try and stress the importance of completing a course of antibiotics because many just stop when it seems to be getting better. If it is a recurrent problem for the patient, it's maybe worth checking their complaints of treatment before optimizing a skin swab. Okay, we've made it to the end. I just wanted to say, if you've made it this far, thank you for watching and for your support. I hope you've learned something. Prior to this, I had absolutely no idea how to use PowerPoint, so apologies for the slides, but I'm sure we'll get better. We all have to start somewhere. Hi, everyone.